Hello everyone. Thank you for joining us today. I'm Angie Aguirre from the Center for Developmental Disabilities Evaluation and Research at the Shriver Center, UMass Medical School. On behalf of Gail Grossman, Assistant Commissioner for Quality Management at DDS, I am pleased to welcome you to the 5th webinar in our ongoing series of topics related to enhancing quality supports for people with intellectual and developmental disabilities. These webinars are brought to you in partnership between CEDAR and DDS. I'd like to introduce our speakers for today, Courtney Dutra and Alex Bernardi, our researchers at the Shriver Center UMass Medical School who've been studying falls in the ID population for the past 8 years. They conducted a statewide falls prevention pilot in 2011 to reduce the rates of falls and train DDS providers on falls prevention risk factors and prevention strategies. They are currently working with visiting rehabilitation services on a grant funded by the Agency for Healthcare Research and Quality to study specific fall prevention intervention programs in residential group homes. Melissa Pepin is the Therapy Services Director at LifeStream, Inc. She led efforts to create the agency's internal falls prevention program and actively manages the ongoing implementation. She has participated on numerous statewide fall prevention initiatives and has over 20 years of experience in the ID population.
Thank you, Angie. This is Courtney Dutra, and I am pleased to be speaking with you today about falls prevention. Welcome, everyone. Our agenda today is as follows. We'll do a brief overview of the falls data in the DDS population, talk about fall risk factors, prevention strategies, how best to assess a person's fall risk, and then Melissa from Livestream will share her experiences in creating and maintaining an internal falls tracking system. We'll do a quick case study and then take questions and answers at the end. On your screen, you may see a Q&A pod in the bottom left-hand corner. Please feel free to type questions there. We'll answer questions at the end of today's presentation. And please note that you won't see other people's questions. You'll only see your own as you type them there. National literature suggests that about 30% of adults with intellectual and developmental disabilities fall each year. About 2/3 of adults who fall will fall again, and we know from the national literature that 15% of falls result in serious injury. And these are the falls that would typically get reported into the DDS HCSIS incident management system. So let's extrapolate this 30% number a little bit. DDS serves approximately 9,000 people in their 24-hour residential settings. And if we know 30% of that group will experience a fall, we can guess that there are roughly 3,000 people who fall each year in the DDS residential programs. Additionally, we have 3 recent data points to help us understand the extent of falls in the DDS population. We have our HCSIS data, and if you don't know, HCSIS is the Home and Community Services Information System. This is a system that service providers use to record their incidents, and it's important to know that only falls that get reported in HCSIS are the ones that result in serious injury or hospitalization. So in one analysis in 2006-2007, this is a 1-year time frame, we found that there were 1,500 serious injuries related to falls. Now we learned on the last slide that about 15% of all falls are serious ones. So from this number, we might guess that if 1,500 is 15% of all the falls that are happening, we might guess that there are as many as 10,000 falls occurring each year in the residential programs. Secondly, we have our Stop Falls pilot data. So in 2009, DDS and CEDAR coordinated a falls tracking pilot study with 5 providers around the state, including Livestream. And the purpose of this pilot was to track and assess all falls, regardless of injury, experienced by participants for 6 months. And so over a 6-month time period, we had 473 falls for 910 adults. This is a rate of about 51 falls per 100 people. And this group includes residential day and individual supports. 10% experienced more than one fall, and in total, about 24% of all the adults in residential and day who were enrolled experienced one or more fall. And again, these are all falls, not just those that resulted in serious injury. Lastly, we have an ER visit analysis that was done in 2011-2012. Again, this is a 1-year time frame. And from this analysis, we learned that 31% of ER visits in the residential DDS population and individual supports were from physical injuries. 49% of those injuries were from falls. So hopefully I've got your attention now about the extent of falls in the DDS population. And what else do we know from data nationally? People with intellectual and developmental disabilities have a similar risk for falling and a similar risk of injury from falling as the elderly population, but at much younger ages. And many of these adults are in the residential programs. So in one study, they found that 57% of people with ID living in residential settings experienced one or more fall over a 33-month period. In a 2010 study, falls were more common among people with ID aged 18 to 64 than the general population. In that same study, this group of adults aged 18 to 64 were significantly more likely than the adults in the same age group in the general population to experience at least one injury caused by the fall. But why do you think younger people with intellectual disabilities are at risk for falling? And I wonder if that surprises you or if it's something that you have suspected for a while. Well, as it turns out, the elderly population and people with intellectual and developmental disabilities share many of the same risk factors. These include poor eyesight or vision loss, especially as the person ages, weak muscle strength, especially in arms and legs. And why would that be important? Well, weak muscles affect a person's balance, gait, and ability to catch themselves before falling. It may also make it more difficult for someone to get out of a bed or a chair or up from the toilet, and that can lead to somebody becoming more unsteady and experience a fall. Weak balance, unsteady gait, elimination problems. So you have to imagine if someone is hurrying to the bathroom, for example, maybe due to a urinary tract infection or an inability to control their bladder, if they're hurrying, they're probably less likely to notice tripping hazards or be aware of their surrounding environment. And if they do stumble, they're probably less likely to catch themselves because they're so focused on getting to the bathroom. Previous falls are a risk factor for more falls, and we see this over and over again in the literature. Each time someone experiences a fall, it increases their risk of not only falling again, but of eventually suffering a more serious injury from that fall. And so you may see this in your own programs, that person who stumbles 5 times and catches themselves, but on the 6th time, they lose their balance, they fall down, they suffer a concussion or maybe a fracture. So it's all those little stumbles that lead up to a more serious fall. And we would encourage you to think of every stumble or every near miss as a risk factor for a more serious fall. And what you want to do is try to treat the underlying cause of that stumble. And we'll get to that in just a moment. Here are some other risk factors that might appear suddenly, often at the onset of an illness, or maybe after starting a new medication. These can affect a person's balance and increase their fall risk. The dizziness, the low blood pressure, the fatigue. Dehydration and urinary tract infections people don't always think about, but those are conditions that can affect a person's balance, make them more dizzy, decrease their blood pressure so that they, again, have more dizziness. And a special word on low blood pressure, dizziness can be in place for as long as 25 to 30 minutes after someone moves from lying down or sitting to a standing position. And this condition is called a postural hypotension, and it can be a result of dehydration or certain medications. It may also be linked to diabetes, neurological conditions such as Parkinson's, or an infection such as urinary tract infection. And in research that's been done in nursing homes, they've shown that most falls happen after a meal. And so to be aware of that, if somebody is already at a fall risk, you may need to provide some extra supervision around meal times, or be aware that they can be more unsteady in those first 25 to 30 minutes after rising. A special word on vision loss. So this is some data that was collected in 2011, and this is from the DDS population. 41% of adults have some form of ocular anomaly. And so this means that there's something with their eyes or vision that is not typical. 17%, so almost a fifth of these adults have significant vision loss, and about half of that group is 40 years of age or older. And so I don't know about you, but 40 sometimes feels a little bit young to me for somebody who would have significant vision loss. So just be aware that this occurs at younger ages. So what are some things you might see? So you may have people with glaucoma, and I like this picture here because it really shows you what a person with glaucoma, how they see the world. And you can tell that the periphery vision is darkened there. So if somebody has glaucoma, it might be harder for them to see environmental hazards, such as clutter or things they might trip over. Similarly, if somebody has a cataract, here we see a picture on the left is nice and clear, on the right is a cataract. And so you can see how fuzzy that would be for somebody. So again, you'd want to make sure that pathways are clear so somebody doesn't trip. Impaired depth perception is also a vision-related risk, as is poor edge contrast sensitivity. And this means that somebody might have difficulty with distinguishing between finer and finer increments of light versus dark. This increases the person's fall risk if they need to step down from a curb onto a similarly colored pavement, for example, or fails to see a step that's the same color as the carpet in the room. So let me show you an example. Here we have somebody's nice living room, and it's hard to tell, but on the right, the entire right side of this room is raised. It's very difficult to see because the raised portion is the same color as the carpet. In addition, the linoleum is very similar to the color of that carpet, and somebody with a vision related risk might not see that step and would trip over it. Here's another example from my friend's house that I took. You'll see that we have the multivariate carpet, but they've done a little better job here by distinguishing the edge of the step with that white and the black. It would be even better if they used a bright neon tape. So you can buy neon green, neon yellow tape. And we would encourage you to mark the edge of the step so it's easily seen by somebody, so they're less likely to trip. Blur from lower lens of multifocal glasses can also be a tripping hazard. Decreased ability for eyes to adjust to light, and sensitivity to glare. So here is a bright room. If somebody walks in and they're sensitive to that glare, it just makes them less likely to be aware of their surroundings and more likely they might trip in the environment. A reminder here that each person should have their vision checked at least annually. Here are some conditions that are associated with increased falls risk, which means if you have one of these, you are more likely to have an increased fall risk. Seizures, aggressive behaviors, which people sometimes are curious about, and you have to imagine if somebody's having an aggressive behavior, what are they doing? They're pretty focused on what it is they're having the behavior over, whether that's another housemate or maybe something in the environment. And because they're so focused, they're probably not noticing the environment. So they may be more likely to trip if they lose their balance, probably less likely to catch themselves. So just be aware of this. Impaired ambulation or mobility, osteoporosis is another associated risk factor. Medication use is a big risk factor, and usually the rule of thumb is if a person is on 4 or more medications, it increases their fall risk because of the side effects that many of our folks are on. So dizziness, confusion, fatigue, sleeplessness, all this can affect a person's fall risk. In particular, anti-seizure, psychotropic, and antidepressants are most likely to cause these side effects that result in falls risk. And just be aware that new drugs can cause new interactions. And at the end of the presentation, we have a handout for you that you can download. It's a PDF that lists specific medications by name that have been shown to increase a person's falls risk. Of course, we can't talk about falls risk without mentioning the environment. Slippery or wet floor surfaces, I think most people think of that. Low seated chairs or toilets. This is something that may not occur to you right away. So if you have those couches that are low to the ground or those toilets that are low to the ground, and you've ever noticed somebody struggling to get out of it, you have to think that it takes a lot of balance and a lot of leg strength to get up from a low-seated piece of furniture or toilet. And so if you have those in your programs, we would say to replace them or try and use some supports like grab bars or something the person can use to hold on to get out of that furniture. Poor or dim lighting, lack of bathroom handles. I like this picture here because it has a couple different grab bars. And a good rule of thumb when you're installing your grab bars is to look and see where the person naturally reaches when they're sitting down, and then put the grab bar there. So that will work better than a staff person going in and trying to decide where the person needs the most support. Clutter is a big environmental risk factor. I don't know how many people have living rooms or offices that look like this, but everybody in the room here raised their hand, so I think we're all guilty of this. But as you can tell, it's a very narrow pathway for somebody to pass. So get rid of the clutter as best you can, and that'll help improve a person's risk for falling. Unstable furniture, lack of handrails on stairs or steps. I think we're all pretty good about having a handrail on at least one side of the stairs, but we would encourage you to put a handrail on the other side too, so that people, if they only have use of one arm, for example, that they have support going up the stairs and down the stairs. Broken canes, walkers, wheelchairs, they're not doing anybody any good. If they're broken, they're not doing their job, so get rid of them. Improper footwear. Here we have 4 types of shoes that are not great for falls risk. Those backless shoes, slippers, high heels, and that one on the left, the bottom left, is a smooth leather sole, which just means the person won't have much traction. They're more likely to lose their balance or to slip, and that would make them go down. So let's briefly talk about a few prevention strategies. A medical strategy you may want to consider is to recognize signs and symptoms of underlying diseases that may be increasing a person's falls risk. This could be things like dehydration, urinary tract infection, constipation, the visual disorders that we discussed. Review medication usage and potentially discontinue inappropriate or excessive medications. Diagnose and treat osteoporosis. Sometimes people are not aware that an individual has osteoporosis until they have a very minor fall but suffer a very major injury because of the underlying osteoporosis. And DDS has a current recommendation to begin screening for osteoporosis as early as age 50 if risk factors are present. And those risk factors include the use of anti-seizure and antipsychotic medication, lack of exercise, poor diet, and women who are postmenopausal. Rehabilitative strategies, this mainly consists of exercise programs You know, we've had physical therapists come in and talk with us, and they say that walking is the best exercise you can do to improve your balance, your coordination, and also to build up strength in your legs. So a simple walking program can make a big difference. You can also have programs that are geared particularly towards increasing balance, strength, and flexibility. Ensure the footwear fits properly, and consider canes and walkers to improve balance. At the end, we have a handout for you that's a simple one-pager of simple exercises you can do with people to help build strength and flexibility. Environmental strategies, I think we've mentioned most of these, but just a reminder that you want to reduce the clutter, install the grab bars, replace the lights, especially now that it's so dark in the evening times. I don't know how many of you come home and you have those lights that are burned out, and so you take a light bulb from somewhere else in the house and you move it to that one spot, and take another light bulb, move it to the next spot, and these light bulbs just keep getting moved around, and one area of the house gets darker and darker. And that just makes it more difficult for people to navigate their environment. Remove your unstable or low furniture, and again, use that color contrast on stairs in particular to help people see better. You can also simplify the environment, reposition furniture. We've seen people trip over rocking chairs, for example, and if you have a rocking chair, you might consider spinning that so the base is facing towards the corner so the person won't trip over that. You can consider door alarms. People who need supervision when they're walking around, a door alarm can help alert staff the person's up and moving. Okay, so fall assessments. How can you decide who is most at risk for falling? Well, DDS has a very nice falls risk checklist, and this is identifies the most common risk factors. These include things like taking 4 or more medications, unsteady balance, a previous history of falls. And we would recommend that you assess fall risk at least annually, although I know many providers do it more frequently than that. Here's a web page where you can download this from, but this is also available at the end of our presentation. We'll have this for you to download, and also that link will be there again. And people always say, well, how do you know how much risk the person has? And it's really a spectrum here. So, the fewer risk factors you have, usually the lower risk you are for falling, whereas the more risk factors that are present generally means just a higher risk you are for falling. Another fall assessment you can do is a time to get up and go test. So you would have a person rise from a seated position, walk about 10 feet, turn, walk back, and sit again. And then you want to observe that person, look at their balance, look at their gait. We generally say if the person looks unsteady, they probably are, and you may want to refer the person for occupational therapy or physical therapy. This is a good handout here, which we'll have for you at the end. It's from the CDC, but it gives you more specific instructions on how to do a time get up and go test. So just to summarize here, these are really the main fall prevention components. So you want to assess the risk factors that are present using a fall risk assessment. From there, you'll most likely develop a care plan that'll give you some ideas of strategies to reduce falls. That'll be your intervention, whether those are medical programs, exercise programs, modifying the environment. And then you want to follow up. And how you follow up is by conducting a post-fall assessment. And a post-fall assessment will allow you to gather more data on that fall and will give you information to help you decide whether you should modify your intervention. And you may decide that you want to collect more data than just those that's being collected in HCSIS for serious falls. So you may consider tracking all the falls that occur at your programs, and that's what Melissa will speak about more in a minute. And the impact of all of this is to reduce a person's fall risk or the fall incidence. And so post-fall assessments, we call this a splat. So when you assess a fall, you're looking for the symptoms that preceded the fall. You want to assess whether or not this is the first time they've fallen or if this is becoming a pattern, the location of the fall, the activity at the time of the fall, time of day, and assess trauma. So I'm going to turn it over to Melissa Pepin now. She can speak more about Livestream and about their falls prevention program they've set up, particularly how they're tracking internal falls.
Thank you, Courtney. Livestream was founded in 1976 by a group of parents seeking better services for their adult children. Livestream currently provides services to approximately 330 individuals throughout rehabilitation, supported employment, 24/7 residential homes, individual supports, shared living, and AFC homes. We participated, as Courtney said, in the Falls pilot program in 2009, and we did learn a lot. After completion of that program, we felt we needed to continue our falls prevention program. And when you provide services to a large number of individuals, you don't grasp the size of an issue until you start tracking the data. For Livestream, individuals are assessed for falls as part of their acceptance into Livestream programs. Our standards committee has modified an assessment that we found to better meet our needs. It's separated into categories such as mobility status, weight-bearing ability, sitting balance, physical limitations, current hearing and vision status, medical considerations such as seizure disorder, orthostatic hypotension, if they require O2 therapy, for example, their mental status, if they're able to follow directions, if they have any behavior risks, and if they're on medication therapy, such as if someone is taking antipsychotics, antidepressants, anti-anxiety medications, pre-sedate medications, antihypertensives, or seizure meds. A final score is tallied, and that gives us the risk factor of the individual. If somebody is high risk, a care plan is developed, and we review their status quarterly. If their score deems that they're at moderate risk, the care plan is reviewed semi-annually, and if their score shows low risk, there usually is no follow-up unless they've had a change in status. And anyone can be reassessed at any time if there is a change in status. We do environmental assessments in homes and at the day programs. For example, some things that we're looking for is if furniture is blocking walkways. And then we may set up the furniture differently to eliminate the fall risk. We also check to make sure, as Courtney said, there's enough lighting in the rooms for individuals, and if there are area rugs, because we have found that people do fall as a result of area rugs. Now we do post-fall reports. The staff member who witnesses the fall completes the post-fall report. And if an individual reports a fall, the staff completes the post-fall report based on what is reported by the individual. And if at any time there's any question as to whether or not somebody hit their head, they're sent out to the emergency room for evaluation. We actually use the post-fall report from the Falls pilot program, and we modified it to meet our needs. We added a narrative so that staff could actually write what happened, because the post-fall report doesn't give you a lot of information. The manager then looks back to see how many falls have occurred within the last 6 months, and were any of the falls reported in HCSIS, and then has a fall assessment been completed, and what is their risk level. And they also document if there is a care plan in place. And the managers always attach the care plan to the post-fall report. It then goes to the residential director, who reviews everything, and then they add comments as to whether a fall assessment needs to be completed if they haven't already been assessed or if there has been a change in status. They also, does the care plan need to be modified? There may be a new risk factor that has developed that needs to be added to the care plan. Does a care plan need to be developed? And does the individual need to be referred to the agency IDT risk committee for review? Our risk IDT committee meets twice a month, and sometimes we need to discuss the issues concerning falls risk at that time. The information from the post-fall report is entered into the HCSIS as an optionally reported event, and the original report is filed in the confidential record, and then copies are sent to the residential coordinator and myself. Now we started tracking just to see if there are any trends regarding the falls of the individuals supported by LifeStream, and we were using the ORE reports to track the falls. The ORE reports aren't very user-friendly, so we developed our own database to track the falls. And the information we enter into the database is from the post-fall report, and we can develop reports based on the location of the fall, the time of the fall, the activity at the time of the fall, whether or not the fall prevention devices were utilized, if there was injuries, and how often individuals are referred to our IDT risk committee. The database allows us to print reports based on individuals and service areas and specifics regarding the falls. And we include all individuals, not the individuals just supported by DDS, because we have other individuals that have other funding sources. And like I said before, we're able to review the falls and analyze any trends. Training. All staff people receive fall prevention training annually. We've included it in our annual list of trainings. And then fall risk information from their assessment is included on consumer-specific checklists. The consumer-specific checklist is something that includes everything you need to know about an individual, that is updated as needed to assist staff in providing the best services possible for each individual. We also conduct trainings for the individuals, and we developed a falls risk brochure from the training materials that we received during the pilot program to use as another training tool for staff and individuals that we can pass out at any time. As a follow-up training, we have a PT on contract that can complete any home safety evaluations and provide us with recommendations. She'll go in and do an environmental, and she may find things that we may miss. There's also a movement disorders clinic in Providence, and the goal of that clinic is to evaluate and treat motor control disorders. There's a syncope clinic at Beth Israel Deaconess Hospital in Boston, and they are dedicated to the discovery of connections between brain, gait, and balance in aging and disease. Syncope may be associated with a sudden fall in blood pressure, a decrease in heart rate, or changes in blood volume or distribution, and the person usually regains consciousness and becomes alert right away, but may experience a brief period of confusion. And as Courtney mentioned before, we are also working in collaboration with Visiting Rehab Services for customized intervention. We are currently participating in the grant program, and they're evaluating and treating individuals in our residential programs, and staff are documenting any falls that occur during and after the treatment. Now we look back to see, we wanted to see if our falls pilot prevention program was working. So we took information from the results of the pilot program and used the same time frame between each of that pilot program and the same time frame from this year. So in March to August 2009, we had 63 individuals and we had 166 falls. In day program, there was 83 falls, and in our residential programs, there was 83 falls. Our latest statistics show that from March to August 2014, we had 35 individuals and 56 falls. There were 37 falls in our day program, and there were 19 falls residentially. In our day programs, there's a lot more individuals, there's people in wheelchairs, there's chance of falling is greater. And we use data from HCSS to gather this data. So what have we learned? The most important thing we've learned about falls prevention is education of staff and individuals. Falls happen, it's how we respond to each one that determines future falls. It has been previously reported that when a person has one fall, they're at risk for future falls. And if we are diligent when someone has their first fall, we're more likely to prevent future falls. And our program has been successful in decreasing total falls. The reduction by individual is 44.5%, and the reduction in the number of falls is 66.3% from the falls pilot to now. Now I'm going to talk about a case study. It's a 72-year-old individual that has multiple diagnoses medically and psychiatrically. And his psychiatric and medical issues were impacting his gait and ambulation safety. His fall risk was assessed, and he was determined to be high. And the most important thing that we thought for him was to keep him in his home. And we had to do some things to reduce the falls and increase his safety. So one of the things we did was we had to put in a transition wedge with a railing that would help him leave his bedroom. We also had a bed alarm that we were using with him, and it was to let staff know or become aware that he was standing up from the bed. He used half rails for support that helps him stand up from sitting down. And then we also have to use a gait belt and a wheelchair PRN depending on where he is medically at that particular time. And he did participate in the Falls Pilot Program with Visit and Rehab Services. The result of this was that he had a decrease in falls, and he was able to stay in his home safely.
So here we have just a few DDS resources and other resources listed here. And what we're going to do here is just switch the view on your screen to a different view so you can see some PDFs to download. And we'd also love to take questions. There is a little Q&A box there. So if you'd like to type questions there, we're happy to answer them. I'm going to switch screens. Here we go. So there's the contact information for myself and Melissa. The bottom left-hand box, those are PDFs that you can download by selecting each one and then hitting the download file button. And the box on the right are some web links. So there's DDS falls prevention information, vision awareness. Sorry, Melissa, I misspelled live stream on this page. I'm sorry, I just saw that. So there's a link, though, that goes straight to the live stream agency. I think so. We have a couple of questions that are coming in. So it looks like we have one here from Melissa. She's going to answer that.
Question I have is, do fall prevention strategies always work? The first thing you want to do is eliminate the reason for the fall. And usually through environmental manipulation. Sometimes you have to try different things till you find the one that really works for each individual. Like I said before, we have people that use chair or bed alarms and floor alarms, and that's usually to alert staff and to act more quickly when someone has stood up. It may not always prevent a fall, but that in combination with other fall prevention strategies work to decrease the number of falls.
Great. Thank you. We have another question here.
Does everyone that falls have subsequent falls?
That's a good question. Every time somebody falls, are they guaranteed to fall again?
Not always. Sometimes it is related to the weather, where there's ice and they fall. Sometimes at day programs, there's a lot of individuals, they may trip over, another individual will miss the chair that they've want to sit in. And sometimes, like Courtney said, the falls are related to a behavioral incident, and that doesn't always occur again. So second falls don't always happen.
So somebody's asking, where can I find the most updated fall risk assessment on the DDS website? So the PDF we have listed here that says DDS, that's the one straight from the DDS website. And on the right-hand side, one of the links says DDS Falls Prevention Campaign. If you go to that page there lists all the different things that DDS has for falls prevention, and including a link on that page that goes to the PDF of the falls risk checklist.
One of the other questions is, how do we reach Visiting Rehab Services? And you can go to their website at visitingrehabservices.com.
Here's a question for Livestream. It says, did the interventions you implement cause unexpected costs to the program?
Yes. Not all prevention strategy, not all was covered by insurance, so we do have to purchase some of the interventions.
Are there some things that you were able to do that didn't have a cost?
Usually like the wheelchairs, walkers, things like that are covered by insurance, although they have to be medically necessary. So you have to justify the use to be covered by insurance.
Although if somebody's tripping over clutter, that one's free.
Yes, there are some things that are free. Moving furniture, reducing clutter, those are free.
Increasing the lighting.
Yes, light bulbs.
Light bulbs. We have a question here about what was the location of the abnormal movement site? I think that's something Melissa mentioned.
Yes, it is the, it's at Butler Hospital in Providence. It's the Movement Disorders Clinic.
Butler
Hospital in Providence. And the CQP clinic was at Beth Israel Deaconess Hospital in Boston.
Great. Any other questions? Anything else that's burning on your mind? Okay. If not, we'll leave the screen up just for a little bit longer here so you have time to download some of the PDFs and go to the web links. Otherwise, we thank you for participating. Oh, we do have a satisfaction survey. That's right. We'd love to have your feedback. There is a link to that. Also, it's a webinar participation survey. And if you stay on the computer for a few minutes, when we close the room, that survey will automatically open and you can fill it out there. And our next webinar, one more question. Do we get a certificate for this training? Well, what we can do is after today's training, we'll send you a thank you for participating email, and that's really the best we can do. We don't issue any kind of certificates or contact hours, unfortunately. We're also recording this webinar, and in the thank you email we send, there'll be a link to that recording, so you can use that for staff training purposes or just to review again at your leisure. And the next webinar that DDS is doing is in February of next year, and that'll be on emergency room, how best to support somebody in the emergency room and how best to provide advocacy. So be on the lookout for that. Otherwise, we look forward to hearing from you through email, and just thank you for participating.
Thank you.
Thank you.